Welcome to the ECG 5-Minute Consult, brought to you by paramedic Troy Kennedy, Dr. John Hayden, and myself, where we guide you through the basics of ECG interpretation based on the primary survey approach from our book, ECG for First Responders, available on Amazon. Let's get started on today's case. You arrive on scene to the home of Mr. William Morrow, who is a 39-year-old firefighter who complains of dyspnea on exertion. He states that the prior day he spent approximately 4 hours fighting a fire in a plastics factory, and that it was during that event that he first began feeling symptoms of difficulty breathing. He was able to continue functioning, but the sensation returned when he exerted himself later in the day while playing soccer with his fellow crew members. The symptoms abated until just a few minutes ago, which prompted him to call 911. He currently denies chest pain or pressure, palpitations, abdominal pain, nausea, or vomiting. He has a past medical history significant for hypertension and hypercholesterolemia, which are being treated with lisinopril and atorvastatin respectively. You obtain a 12-lead ECG, but before we examine it, let's review our primary survey of interpretation. We use the ECG primary survey approach to quickly identify potentially life-threatening emergencies. In this approach, we seek to answer these 4 questions. 1. Is the heart rate too fast or too slow, causing cardiovascular instability? 2. Is the rhythm supraventricular or ventricular in origin? 3. Are the ST segments consistent with an ST elevation myocardial infarction STEMI or a non-ST elevation myocardial infarction NSTEMI? And 4. Are the T waves consistent with a STEMI or NSTEMI? With this in mind, let's take a look at our patient's ECG. First, the rate. Looking at the QRS complexes, they appear to be occurring at regular intervals. Now in this particular ECG, we don't have a QRS complex that's perfectly in line with one of the bold lines on the graph paper. That makes it a little bit harder to eyeball, but we can still get an accurate rate by looking closely and counting the number of small boxes between R waves. If you zoom in here, you can see that there are actually 15 small boxes between these R waves. To calculate the rate, we'll divide that number, 15, into the number 1500. Now why 1500? Well, here's a look at the math behind that. ECG paper is printed at a speed of 25 millimeters per second. If you multiply that by 60 seconds, which is in a minute, divide that by the number of small squares, that'll give you the rate. So essentially it boils down to 1500 divided by the number of small boxes between R waves, in our case 15. And for this ECG, that gives us a rate of 100. So you could alternately see that 15 small boxes would be equal to 3 large boxes, as each large box is 5 small boxes. But I want to introduce this just in case you have a number of small boxes that aren't evenly divisible by 5. Looking at the rhythm, it seems that the QRS complexes are wider than normal. Zooming in, we can see that ours are about 4 small boxes wide. And a narrow QRS complex is one that's less than or equal to 3 small boxes. So even though our QRS is widened, we can still discern P waves, and each of those is followed by corresponding QRS complex, and they are upright in lead 2, which is the lead that follows the normal direction of electrical conduction. Taken together, we suspect that this rhythm may be supraventricular in origin and is an exception to our 3-box rule. Now this may be explained by some type of conduction abnormality within the His-Purkinje system of the heart. So even though the source may be originating where it should be, which is the sinoatrial node, slowed conduction can cause the QRS to widen like we see here. Moving on to the ST segments, we can see that there's ST elevation in leads V1 through V4. There's also depression in leads 1, V5, and V6, while the remaining appear to be isoelectric. So is this a STEMI or an NSTEMI? Well, the answer to that is complicated, so I'll have to leave you in suspense for a couple of minutes while we finish looking at the T waves and then answer a question about this abnormality. Looking at the T waves, there appears to be abnormally inverted T waves in the lateral leads, that is leads 1, AVL, V5, and V6, while the rest appear unremarkable. Now that you've examined this patient's ECG, which of the following ECG abnormalities will you report when contacting the receiving hospital? A. Sick sinus syndrome. B. Left bundle branch block. C. First-degree AV block. D. Atrial fibrillation. Or E. Supraventricular tachycardia. The correct answer is B. Left bundle branch block. Remember when I said that the patient's name is William Morrow? That was an Easter egg to clue you into the mnemonic device that is commonly used to discern between right and left bundle branch blocks. Now, since bundle branch blocks cause impaired or slowed conduction, the ECG will show a widened QRS complex, that is greater than 120 milliseconds or wider than 3 small boxes. In the case of a left bundle branch block, look for a W-shaped QRS complex in lead V1 and an M-shaped QRS in lead V6. For a right bundle branch block, look for an M-shaped QRS complex in V1 and a W-shaped QRS complex in V6. And here's another little graphic to help demonstrate that. Here's the same information, but with the ECG zoomed in to only include leads V1 and V6. One more quick method of telling apart the two is the turn signal method. Maybe you're on day 1 of your paramedic internship. You're too nervous to remember the mnemonic, but you can tell that there's a bundle branch block of some kind going on here. You can use this. Just turn the ECG paper clockwise, and you'll see that in a left bundle branch block, the QRS complexes in lead V1 will be pointing to the left. And in a right bundle branch block, the QRS complexes in lead V1 will be pointing to the right. I included a couple other examples here to help you practice. Go ahead and pause the video on each one and take a look in the context of what you just learned. So this one is an example of a right bundle branch block. And this one is an example of a left bundle branch block. Circling back to those ST segments, we saw that they were abnormal, but I want to explain this more now that we know that the patient's actually having a left bundle branch block. Because in the left bundle branch block, we do expect to see some ST elevation in the anteroseptal leads with depression in the lateral leads as a common finding. Determining whether or not the patient's actually having an MI in the presence of left bundle branch block, it's difficult, it's an advanced topic, and is really beyond the scope of today's lesson. If you are interested, I'll give you the homework assignment of looking up Scarposa's criteria to tell an MI in the presence of a left bundle branch block. Well, that's all for today. We hope you've enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about the basics of ECG interpretation, check out our book, ECG for First Responders, available on Amazon. We look forward to seeing you again next month.